Hi guys, I think I'll start the skeletal dysplasia series. Like I told you that I'll present this in 3 sessions. We did more like an introduction or an overview of the skeletal dysplasias last week. So what I will do today, I will be showing you some ultrasound scan features that you have to watch for. Then I'll go into the specific conditions. I'm hoping that if I show you some ultrasound scan features of skeletal dysplasia, it will make us probably cruise through the specific conditions of the skeletal dysplasias. I hope you can see my screen where you are. I'm about to go into slide share now. All right, so here we go. So let's duplicate this. Right. Sorry, I have to go to the slide where I was. I think we covered all this last week. For those who did not attend the last session, this same presentation is available on our YouTube channel. So please go to our YouTube channel and cover the gap you may be having. I've just put these graphs here to show you that whenever you measure the long bones, and they are all borderline. This is part of screening for skeletal dysplasias. These are borderline short long bones. They are not extremely short. There is a difference between these bones, the size of these bones we are looking at here, and these ones. So you can see the clear distinction that these ones are marginally short long bones. You can see the tibia, the ulna. We can also see the, just a second. Right, so we can see the difference here that these are marginally short, while the other ones are extremely short. So you need to make this distinction. The marginally short long bones, there's many other causes besides skeletal dysplasia. You also have to think of things like the trisomies and so forth for the marginally short long bones. But for the extremely short long bones, invariably you are dealing with a case of skeletal dysplasia. So be aware of this when you do the measurements and you plot the long bones. You can see the fibia, tibia, radius, ulna, and of course there is also the femur, which I didn't put there, in the humerus. They were equally short, like these are the long bones. When you are referring to hypomineralization, this is what you refer to. If you check, this is the skin. You can see that in this case it was the femur, that the femur echo appearance or echogenicity is almost the same as that of the skin there. This is what we mean by reduced echogenicity or hypomineralization of the long bones. So if you come across a baby whose bones, they almost look like the skin, you can see there's no echo density, which we are used to when we are measuring the femur here. So that's the hypomineralization. That's what we mean by hypomineralization of the long bones. These were extremely short long bones and also hypomineralized. If you look, this is the thigh. From day to day is the thigh. This is the knee joint, and this is the leg and the foot. You can see again hypomineralization of the forearm bones, the tibia fibula. They are barely visible, right? And this was a baby with extremely short lower extremities, as you can see there. Again, to show you about bone there, this was probably either what we measured. Okay, I think it's not appearing. We measured either as the tibia or the fibula. You can see that it is bowed here. Not a typical telephone receiver, but it's clear that it is a bowed. It's not a straight leg bone there. Then when we look at the thorax, this is the thorax and this is the abdomen. You can see by just eyeballing this image that there is a disproportionate in the size of the thorax and the abdomen. The abdomen sometimes looks bigger than just not age, or it is within normal, but certainly the thorax is narrow and small. It's a small, narrow thorax, as you can see. Some refer to it as a barrel shaped thorax. So that's a small thorax when you compare it with the abdomen. This is where the thoracic abdominal ratio comes into play. This is how we measure the thoracic circumference. You can see we use the ribs. These are the ribs here, and the front is the sternum. So you use the ribs and the sternum as your landmarks to do the thoracic circumference. Yeah, remember what we said about the thoracic circumference, that we use the thoracic abdominal circumference ratio as a way of trying to predict the lethality of the condition, to say, is this a leader? Skeletal dysplasia is not a leader, because obviously if the thorax is not growing, then you are more likely to have small lungs, pulmonary hypoplasia. The lungs will not grow as well, because what makes the lungs grow, what makes the condition lethal is in most cases pulmonary hypoplasia. The other markers you may come across is the frontal bossing. We'll be mentioning it as we do the specific conditions. I've just shown you the pictures that you may remember as you go through the specific conditions. Unfortunately, we do not, in our library, we did not put all the images of the skeletal dysplasias we've come across. Still work in progress, but this is frontal bossing. Look at how it is. And there's also a depression at the nasal forehead, nasal interface there. This depression is a characteristic marker of skeletal dysplasia. We normally see this in the achondrogenesis, achondroplasia. These babies will have big heads. So that's another marker which you should look for. Then, of course, I think here we're again just demonstrating hypomineralization of the long bones. You can barely see the tibia and the fibula in this baby, even though the bones of the foot are barely visible. You can see the bending of the spine as part of the lordosis, and also this baby, we thought the trunk looked short when we did the scan, but you can see the abnormal posturing of the spine in this baby. And again, a case of hypomineralization. Look, we can barely see the femur here. That's the femur, and that's the muscle. So that's again a case of hypomineralization of the long bones with reduced echogen. These are just showing the short extremities. This was the humerus. I can see it was short. Look at the center. And there is an application on perinatology.com which we use to try and figure out which conditions we are dealing with. I've just put this these findings as a way of trying to demonstrate to you how it works. For example, if we do scan a 32-week baby, and these are the measurements we have obtained, you can see that the calculator will tell us if we have a microcephaly, then it will tell us about the shortness of the long bones, as you can see, and also possible hypoplastic fibula. Then it will tell us the possible diagnosis. Like in this case, it's telling us that there's possible microcephaly, which may include trisomy, which may be secondary to chromosome abnormalities like trisomy 13, 18, 22, or imprinting disorders like Angelman syndrome or genetic syndrome like Smith-Lemil-Opie syndrome, Cornelia de Lange, Rett, Acadia Gutierrez, and also infections like toxoplasmosis, CMV, Hep, simply it's telling us a whole lot of things. Of course, history plays a very big role here, and the issue of alcohol, cocaine, mitochondriopathies, all these disorders can be linked with this. Then when you are looking at the bones, the micromelia, when there is no more mineralization and no fractures, this could be the thanatophoric dysplasia type 1 or 2, or a short rib polydactyl syndrome, or homozygous achondroplasia, which is usually lethal, and achondrogenesis type 2. And we could also have decreased mineralization with or without fractures. This is where things like hypophatasia comes in, which is perinatally lethal. And we could also have achondrogenesis type 1, which is lethal, and also genetic effector type 2, which is usually lethal. So it also does calculate for us. You can see here the chest to abdominal circumference ratio is 0.61, which is below the 0.8 cutoff, which is acceptable to say, look, the thorax is appropriate. Then it also does calculate the femur foot length ratio, which is about 0.5 in this case, which is the femur length to abdominal circumference ratio. It was 0.1. Then it goes on to say, if a femur length to abdominal circumference ratio of 0.16 associates an increased likelihood of lethality in skeletal dysplasia. So there are other markers of skeletal dysplasia which you should be aware of, like the femur length to abdominal circumference ratio. Then it's telling us that if there is clover-leaf skull, possibly we are dealing with thanatophoric dysplasia type 2. Short barothorax, we have Jaco-Levin syndrome, spondyloepiphyseal dysplasia. Then we have triphalangeal thumb. Triphalangeal thumb is where the thumb is divided, kind of. It's got three phalanges instead of the two, sorry. Normally the thumb has got two phalanges, right, as compared to the other bones. The possibility are Holt oram, then normal variant. We could also have isolated, it could be a normal variant, or it could be an isolated anomaly like trisomy 13 in trisomy 13. It could also be trisomy 13, Vata association, Poland syndrome, fetal hydantoin syndrome, and fungal anemia. If there's club foot, in addition, we could have Lyman is saying he didn't see the thoracic circumference. I inputted it. They didn't show it here on the measurements, but if you look on the right there, this is what I imputed. So just look on the right, there is the thoracic circumference here, which is written 107.8. So these are the values I imputed into the calculator, and this is what the calculator has given me. So yes, then we have club foot, where we have possible idiopathic club foot, arthrogryposis, constriction band syndrome, tibia hemelia, dystrophic dysplasia, and spinal bifida neuromuscular disease. So this calculator is available on the perinatology.com website. This is why in modern medicine you need the internet. You cannot run a clinic where you do not have access to internet. Really, we are in we are the IT generation, right, of doctors, modern doctors. You need the internet. Once you get some answers, you need these applications to help you get some answers. Because sometimes the presentation is borderline or is very confusing. But these kind of applications will help you to narrow down your differentials. Even if you are to do further tests, then you narrow down your test so that you do the specific test instead of just being too general with the test. So remember, perinatology.com website is very useful. It's not only useful for this, we also use it for many other issues, even calculating the the MOM of the MCA PSV. We can also use it to even recalculate the risk for trisomy 21 for second trimester presenters, and so forth. The FMF website also can be used for fetal anemia diagnosis, and also, and also many other things, the vitamins, including how to manage small for gestational age babies if we are stuck. So remember, these websites are very important, very important. Right, so I'll proceed. Now, I'll just go through the individual, the commonest ones. As you saw, there are probably more than 50 skeletal dysplasias. We are not going to go through all the 50. We'll probably go through 10 or so, which are more common, which you may likely come across. So achondrogenesis, the prevalence is 1 in 40,000. It is the second most common leather skeletal dysplasia after thanatophoric dysplasia. The main difference we presented them on the table, probably will refer to them again today. On ultrasound, there is severe shortening of the limbs, a narrow thorax, a short trunk length, and a large head. This is associated with micrognathia, nuca edema, and polyhydramnios. There are two types of achondrogenesis. Type 1, which makes up 20% of them, is an autosomal recessive type, and there is poor mineralization of the skull and vertebral bodies, as well as rib fractures. So take note of this, that rib fractures, you don't just get them in osteogenesis factors, but you can also get them in type 1 achondrogenesis. Then the type 2, which is sporadic, occurs in about 80% of the cases. There's poor mineralization of the vertebral bodies, but not the skull, and there are no rib fractures. I think one of my images of the vertebra, I'm not sure if I put that image. This one is not quite convincing, but you can see some drop down that the mineralization is not what I expect of this. I think I did not put the image, but I think we have one of the images where the vertebra was not well ossified. Not this. I think I didn't put it. Probably I'll just put it so that we can revise it on it next week. So these are the two types. The most important part is to be able to highly suspect also genetic effector. Of course, if we are not sure, anyway, eventually you have to refer to fetal medicine, because the issues of termination, we are the ones who have to deal with these terminations, or counseling for termination or carrying out the procedures. But you should be able to highly suspect. The worst case scenario is to miss that the baby has problems of skeletal dysplasias. Or the other worst case scenario is to falsely reassure the woman that they have achondroplasia when they have achondrogenesis, sort of falsely assuring them that the baby is going to be okay, and the baby will be just like the other short-term, a normal dwarf kind of, which is not the scenario here. Because giving false hope is a little bit tricky in our line of work. So detailed ultrasound scan exam is necessary, and achondrogenesis is due to mutations in the SLC26A2 genes, and also the collagen 2A, one gene, and the TRIP11 genes. For women who desire to know the specific type they have, just remember that a genetic test can be done on the amniotic fluid targeting those genes. When you are doing this test, we have to write that we are suspecting achondrogenesis, and we would like them to look for mutations on these specific genes. As you know that the genes are many, there are millions of them, so that if you just say do a genetic test and look for any defects, most laboratories wouldn't do, unless if you order a whole genome sequence or a whole exome sequencing, then the whole human genome will be sequenced, and any variation from normal will be interpreted. But if you do suspect a certain skeletal dysplasias, due to the issues of cost, you may have to ask the laboratory to test certain specific gene mutations. We have already said the condition is lethal, but some couple will choose expectant, or those for religious reasons may not opt for termination. Then the pregnancy care here is standard. You don't do anything specific, you just follow up these patients in a routine. This applies to all lethal condition. If the couple has a lethal condition and they decline the option of termination, please don't give the couple a rigorous care plan like come and see me every 2 weeks. The question is to do what? Unless if this request is from the couple, because if the couple says, look, we just want you to show us our baby and it's our desire to be interacting with our baby in the uterus, since when it comes out, the baby won't be having a chance, then that's fine. But you shouldn't initiate a rigorous kind of follow-up for a baby. You know that they are lethal. You follow them up in a standard way. When you are saying standard way, what do you mean? We know that after an anomaly scan, women who have low risk should be seen again at 36 weeks if there are no risks to the pregnancy. This is what I mean by standard follow-up plan. Unless, of course, there are other issues, but the couple should always be told that if there are any concerns, they are more than welcome to come back and see you again. Then delivery is standard obstetric care. However, this condition is complicated by the size of the baby's head. So the baby's head should be estimated towards delivery. And normally when beds measure more than 400 millimeters or 40 centimeters, we normally give caution to say, look, the chance that there could be a cephalopelvic disproportion is high. And the couple have to be informed that they may be offered a cesarean to try and overcome this obstruction. This is not a case of ventriculomegaly, so there's no cephalocentesis to be done here. So this couple has to be informed that if the baby continues to grow in the uterus, the head will not stop growing. It will continue to grow bigger and bigger and bigger. And there may be difficulties in them trying to achieve a natural birth. So they should be warned concerning this. Then the condition is lethal due to severe pulmonary hyperplasia. Like we highlighted, these conditions have a small chest and the chest doesn't grow as expected. The risk of recurrence is type 1, which is autosomal recessive inheritance pattern. It follows the Mendelian inheritance pattern. So there is a 25% chance that they will pass it on to the next offspring. So these women should be told this kind of information. In our case, where we are not able to test, or where sometimes the condition will be borderline for you to say, is it type 1, is it type 2? This is the same advice you are going to give to couples. Say, look, there's a 1 in 4 chance that this condition will recur. And the best time to diagnose the condition is not at the 11 to 13 week scan. Of course, at the 11 to 13 week scan, we may see an increased nuchal translucency. It's neither at the 20-week anomaly scan. At the 20-week anomaly scan, what you may encounter are borderline short bones. You know, those bones which are around the 10th centile, and they are not going to cause the woman to panic because most babies with these borderline bones, they turn out to be normal. But you have to advise you that this condition is picked up in late second trimester. That's when it manifests, and hence they have to come in then. There's no increased risk for type 2. So that's achondrogenesis. Achondroplasia, it is fairly common compared to achondrogenesis. It occurs in about 1 in 25,000 births. On ultrasound, the short limbs, short hands and fingers, large head with frontal bossing, and depressed nasal bridge. The kind of picture I showed you, let me just go back to it. And there's lumbar scoliosis. I think I showed you the lumbar part. So this is the kind of picture you get with achondroplasia. You can see the bossing, depressed nasal bridge here, and the lumbar scoliosis we see there. So, yeah, where are we? Right. So the limb shortening and typical facial features become apparent after 22 weeks of gestation. It is due to a mutation in the FGFR3 gene, fibroblast growth factor receptor 3 gene, and he has autosomal dominant inheritance pattern. The diagnosis can be made by invasive testing of cell-free DNA and cell-free DNA analysis of maternal blood, looking for the mutation on this gene, FGFR3. So achondroplasia, because of its inheritance pattern, however, we also have sporadic cases. As you are aware, those who work with us in the fetal defects clinic, you know that we have come across women who have babies with achondroplasia who will tell you that they do not have any family history. So there is a component that comes as a result of de novo mutations rather than inheritance pattern. But generally, it's a condition which is an autosomal dominant pattern. Autosomal dominant means that there is close to 100% chance of the woman having a baby with it. However, autosomal dominant conditions are not all 100% penetrant. They may be, their ability to manifest is affected by many other factors. So this explains why some of the short women we see, the achondroplasia women we see, they carry normal babies. But we know that more than 50% of the ones we have seen already, they'll be carrying babies with achondroplasia because of the inheritance pattern. The follow-up scans are done every 4 weeks to monitor fetal growth and also the fetal head. Standard obstetric care and delivery, then cesarean section if the fetal head circumference is greater than 40 centimeters, like I have already highlighted, that the moment the head goes above 40 centimeters, we begin to discuss with the couple. Let me say that it's not absolute though, because there are some women who refuse our intervention, but this one didn't have skeletal dysplasias. The baby's head measured 40 centimeters, more than 40 centimeters. They refused elective cesarean, and we followed them up. They delivered natural. But all we are saying is that it is a risky kind of which the woman will be taking, because the risk of pelvic disproportion is high when the head is measured 40 centimeters. It's not absolute to say if a woman refuses, then you also have to tell her that, they can still try. The good thing is that it doesn't harm the baby much if the labor is being monitored. Failure to progress is not a very harmful kind of labor experience under good monitoring. So if they fail to progress, then you can convince them to be sectioned. Then prognosis, if it is the homozygotic type, homozygotic type means both the father and the mother pass on the gene to the family. It means we have two short couples. The condition becomes lethal due to severe pulmonary hypoplasia. This is why you see us, you always ask those short mothers to say, is your husband short as well? Because what we are trying to get to, we want to know if we will be dealing with the homozygotic type. To say the baby is inherited two deleted mutated FGFR3 genes from the parents. The heterozygotic type, which is the commonest, actually, I think so far we have not come across the homozygotic. Fortunately, it's very rare. The heterozygotic type, we are saying the mother is short and the father is okay, or the opposite. These are the commonest type, and I think we know of very popular personality even in our country who have achondroplasia. These people have normal intelligence and a normal life expectancy. They may have respiratory limitations due to small thorax and development of stenotic vertebral canal. Peripheral neurologic deficits may decrease the quality of life. We have not come across women like this, the ones who come to us pregnant. Probably the ones who grow to become pregnant are being naturally selected, and these other ones won't be pregnant. But we have not come across, most women we see, they will tell us, well, we have no problem, I have no problem breathing, and they do not have any neurological deficits. Probably the ones we have this, or probably they're on the side of men, or they don't end up being pregnant. Then the recurrence risk, in one affected parent, it is 50%. If the parent is affected, one of the parents affected, if both parents are affected, 50% risk of having heterozygous achondroplasia and 25% risk of having a homozygous achondroplasia and 25% chance of unaffected child. Some of you may ask and say, why are we saying 50% when you are dealing with an autosomal dominant? It is because the parents have to be heterozygous. Otherwise, if they are homozygous, it's lethal. They cannot be alive. So any achondroplasia you see, just know that they are heterozygous. That's why they are alive, and that's why they've grown to the level they are now. Is because they are having a heterozygous component of the condition. Homozygous, they are lethal. They die in uterus or immediately after birth. Those who fail to be picked up, or those who are not terminated. So this is why you see those calculations there. For those who understand Mendelian inheritance, for an autosomal dominant condition where the parents are heterozygous, you know this is correct, right? Right. So de novo mutations, the recurrence risk is low. We do have some parents we suspect to have de novo mutations, and their babies were fine. Then we go to another condition called asphyxiating thoracic dystrophy. It occurs in about 1 in 70,000, fairly uncommon. The phenotypic expression varies. The characteristic features are short, narrow chest with short ribs and mild to moderate rhizomelic femur and humerus. There is limb shortening, which may become apparent after 22 weeks gestation. The condition is also referred to as Jeune syndrome. The associated abnormalities include brain abnormalities. A detailed ultrasound scan is required as part of the investigation. Mutations occur in more than 10 genes. However, about 50% of the cases are due to mutations in the DYNC2H1 gene. Follow-up should be standard for this condition, and standard obstetric care and delivery should be offered. Neonatal mortality, 60% die due to pulmonary hypoplasia. The surviving neonates have normal intelligence, but rarely live beyond the teens because of renal and cardiovascular problems. In autosomal recessive inheritance pattern, 25% recurrence risk. So, very important to remember, asphyxiating thoracic dystrophy is another differential when you see the short bonds. Then we have atelosteogenesis. Again, this one is rare even in fetal medicine symptoms. That means in Zimbabwe, in a year, we may not come across it. We deliver 400,000 women. Maybe we may come across it once in 2 years. So the prevalence is about 1 in 500,000. There's severe of the limbs, narrow thorax, club foot, dislocation of the hips, knees, and elbows. There is association with prominent head, forehead, hypertelorism, micronathia, cleft palate, hitchhiker thumb. You know the hitchhiker when you are trying to stop a lift, hitchhiker thumb. The features are similar but more severe to those of dystrophic dysplasia. Detailed ultrasound scan examination is needed. It is due to mutations in the FLNB and the SLC2CA2 genes. If the mutation in the family is known, prenatal diagnosis is best performed by CVS and DNA analysis. If pregnancy continues, follow-up should be standard. Standard obstetric care and delivery should be given. It is lethal in utero and shortly after birth due to respiratory failure. In the majority of cases, there is no which are the de novo mutations. De novo means new, by the way. De novo I'm not sure which language is this, but de novo simply means new mutation, the mutation which did not exist in the family line before. There is no increased risk if it is due to de novo mutation. In the rare case of autosomal recessive inheritance, again 25%. Remember, whenever you hear autosomal recessive, know that the chance that the woman will pass it on to the children is 1 in 4 or 25%. Campomelic dysplasia, 1 in 200,000. Again, rare in fetal medicine terms. We may encounter just 2 cases in our country per year. That's how rare it is. The shortening and bowing of the long bones of the legs. There's bilateral acute femoral angulation. And there's narrow chest, hypoplastic scapulars, large calvarium with disproportionately small face and micronathia. I suspect we have come across a single case of this in our unit. We may not have labeled it as Campomelic dysplasia, but as a leader skeletal dysplasia because of the features. There is a narrow knuckle edema, club foot, hydrocephalus due to the Atlanta hospital occlusion, and there is polyhydramnios as well. Detailed ultrasound scan examination is required. There is sex reversal in about 70% of male fetuses, and invasive testing necessary to determine the genetic sex. This is very important, this sex reversal phenomena. This is why you should never, at fetal medicine level, never tell somebody that the sex you have told them, never tell them that the sex you have seen on the scan is 100%, because there are very rare abnormalities that could reverse the sex, where the genetic sex and the phenotype sex are different. So remember this. This is why you should not say 100%. You just told them it's 99% until you have genetic sex. Of course, for couples who are having NIPT also tells us the genetic sex. Those are the couples you can confidently say, now we've seen that you have a boy, and the NIPT has confirmed that you have an XY, or those who have done karyotype for one reason or another. We can only say 100% for those kind of couple. So please don't say the sex I've told you is 100%. Always put a disclaimer and say, look, it's 99% because we do not know the genetic sex yet. So this Campomelic dysplasia is caused by the Campomelic dysplasia is caused by mutations in or near the SOX9 gene. If pregnancy continues, follow-up should be standard. The standard of obstetric care and delivery should be done in tertiary center. Mortality in the first year of life, 90%, 5% due to laryngotracheomalacia. Laryngotracheomalacia is a condition where the larynx, trachea, and they are very soft and they collapse with usually breathing or breathing out, one of them. So that's the laryngotracheomalacia. In the majority of cases, which are de novo, there's no increased risk. But in the autosomal recessive type, it's 25%. Then we have craniosynostosis. We do have, I think, 1 or 2 cases in our database. Unfortunately, I did not get the images from our database for this condition. But what is craniosynostosis? It is the premature fusion of the cranial sutures resulting in abnormal shapes of the cranium. It occurs fairly common, 1 in 2,000. It's associated with advanced paternal age. In 90% of the cases, craniosynostosis is an isolated finding. In 10% of the cases, there's an association with one of the 150 syndromes that include Cruzon syndrome, Muenke syndrome, Seth-Chosen syndrome, and Alpert syndrome, and Pfeiffer syndrome. So you can see that is associated with a lot of syndromes, craniosynostosis. So one of the most important parts of scanning a baby with craniosynostosis is to rule out the association, because that will lead us into a syndromic pattern approach. Detailed ultrasound examination, special attention should be paid to the fetal hands, mid-face, heart, and also central nervous system as part of the syndromic pattern workup. Then fetal MRI may provide useful information, especially in the fetal head. Detailed family history and consultation with the geneticist. If the family history is negative for isolated craniosynostosis, prenatal karyotyping to rule out chromosomal abnormalities is recommended. Craniosynostosis caused by mutations in the FGFR2 and also FGFR3, the one that also causes achondroplasia, and twist and EFNB1 genes. These cause craniosynostosis. So you are going to see an unusual abnormal shaped head from the one, the head do not look symmetrical. The way I used to see it when you do head circumference, then we have to suspect craniosynostosis, that is early fusion of the suture lines. Follow-up should be standard obstetric care should be offered, including delivery, but of course, the shape of the head may affect natural birth, because if many sutures are fused, as most of them who are midwives and obstetricians, you know that during delivery, the baby moves along the suture lines when the suture lines overlap. But this baby is already closed its suture lines. So delivery of the head may be tricky here, and offering these women cesarean may be a good option, depending on the size of the head, of course. Sometimes if the sutures are too much, this may cause the baby not to grow to a normal size, so delivery may also be easy. So everything has to be assessed carefully towards the time of delivery. Prognosis. Newborns might have difficulties with breathing, feeding, and vision. Increased intracranial pressure, which is present in 1/3 of the newborns, might affect intelligence and neurodevelopment. Optimal time for surgical repair should be planned. Yes, the surgical repair where these suture lines are opened up to allow the baby's head to grow. Remember, babies are born with small heads and they still have to grow. So this craniosynostosis, this will hamper extrauterine fetal head development, growth. De novo mutations, no increased risks. Syndromic forms with positive family history, the chance is 25% and 50% risk of recurrence depending on the associated syndrome. I think I will end here today. Then I will continue next week in view of our time, so that we finish on time. Probably, if I could do, there's not much on Kuzo syndrome and Muenke syndrome, maybe I could run through these ones, then we finish. I will stop. Then let's go to Kuzo syndrome. It occurs in about 1 in 25,000 babies. There is variable craniosynostosis, most often bicoronal. There's mid-face hypoplasia with big nasal tip. Big means it's looking like a bee. Then we have mandibular prognathism. And exobitism, which is protrusion of the eyeballs as a result of shallow orbits, which is different from the other one, right? Ophthalmologist or something like that. So exobitism. So be aware of these words. Sometimes we say right exobitism, and you wonder what is prognathism. Then there's normal hands and feet. Autosomal dominant inheritance of mutations in the FGFR2 gene is responsible. The diagnosis can be made by invasive testing. Most affected individuals are of normal intelligence. They will have bulging eyes and vision problems due to the shallow orbits. We have the Muenke syndrome. The Muenke syndrome occurs in about 1 in 30,000. There's coronal craniosynostosis. I'm assuming we know where the coronary is. The coronary is the midline. You know, this midline suture that runs from the frontal suture, which is the pragmatic, right? Going all the way to the hospital one at the back there. The one that runs right at the middle of the brain, that's the coronary suture. At the middle of the head, at the top. The mild abnormalities of the hands and feet, including carpal and tarsal fusion, with brachydactyly, things like middle phalanx, and cone-shaped epiphysis. The autosomal dominant inheritance of mutations in the FGFR3 genes and the diagnostic made by invasive testing. Most affected individuals have normal intelligence, but some have delayed development and learning difficulties. I think I will stop here. It's too much information. I'll stop here today and allow us to digest what we've gone through. Yeah, let's stop here today. We will continue next week, hopefully to finish before we go to the Congress, the skeletal and the fetal anomaly series. I think we still have what, 2 more sessions. Yeah, we should be able to finish before we go to the Congress, the fetal anomaly series. Well, this is the last of the fetal anomaly series. I'll put some long bone abnormalities at the end of this one to finish it in 2 weeks. All right. Otherwise, enjoy your weekend and your Friday. We'll meet again next week. This presentation will be available in our YouTube channel as always. So you may go to the YouTube channel and watch the presentation. Otherwise, enjoy the rest of your day.